I've been asked to present the pediatric portion of pain management. This is a physiatrist's perspective. I'm a rehab doctor, and sometimes an anesthesiologist presents this portion, and we have different approaches to management. So I have no conflicts of interest to disclose, and the objectives at the end of this talk are to be able to describe the current WHO ladder of pain management, describe 3 interventions in managing pain in children, and understand risk factors involved in the youth substance abuse of painkillers and addiction. I used to have the classic hallmark slide from the ISAP regarding pain, but now this is a slide that demonstrates the supportive network that's needed in providing care for the special population of chronic pain patients. I think it demonstrates growth in terms of expansion of our awareness of how prevalent this problem is, and also the advancements we've made in the field in such a short period of time. Also the network needed to support, no matter how small it may seem, it may be very relevant to the management and function of the child. New York Times article written by Bafi actually really brought this to light as to how prevalent and how long ago, or not so long ago, the pain in children was really underperceived. For decades, infants and newborns had been undertreated for pain during various procedures. They were just only treated with paralytics. And it was in 1987 that a joint policy statement was issued by the American Academy of Pediatrics and the American Association of Anesthesiologists, acknowledging that there had been anesthetics that had been administered during surgeries that showed a change in physiological responses of these patients, and thus the new development of pain management in this group. How prevalent is this problem? Epidemiologically, in terms of the percentage, it hasn't changed a lot. It's growing. It was estimated in 1991 from Goodman and McGrath that it was about 15 to 20%. There were such huge discrepancies in what was being reported as to who was more affected, what was the age group, etc., that Sarah et al. Issued an article in Pain in 2011 in which they did a systematic review of about 200 articles that were from all over the world. And what they found that was a consistent finding that was that girls were more affected than boys, with increased age, except for abdominal pain. Pain tended to increase. Lower socioeconomic status was a factor reported. Social variables such as anxiety, depression, low self-esteem were found to be factors. And research suggests that the prevalence rates of childhood pain have increased over the last several decades. Risk factors for developing pain, chronic pain, are female to male 6 to 1. Age lower than 5 years of age, it's a lower risk. Greater than 12 years of age as a higher risk. Location, lower extremities are more often affected than upper. Types of pain, boys usually tend to have back and limb pain, girls headache and abdominal pain. In terms of assessment, the Quest approach is what I use in terms of, you look at the child and the parent. From the time they enter the exam room, I kind of look at the body language and who is being the primary historian, which is usually the parent. But if that child is verbal and developmentally able to speak appropriately, question the child first. Frequently the perceptions are not the same. Use of pain skills, which I will get into shortly. You have observational and you have self-reporting pain skills depending on the age of the child. Evaluate the behavior and physiologic changes. So this means from the second you look at, you get a set of vital signs, you know what's going on, and you really examine the patient. I frequently, during the first initial evaluation, disrobe the patient and have them get into a gown so that I can really examine the gait and do a good palpation of the musculoskeletal system. Secure the parents' involvement. If in fact you don't have the parents' buy-in, the children are dependent on the parent really to get to the programs that you're going to be prescribing, to give the medications that you're going to be prescribing. And if in fact the parent has not bought into the plan, you're not going to have a good outcome. Take the cause of pain into account. By this I mean, usually by the time patients have gotten to me, they have had a mega workup, and this workup is usually negative, and the etiology of pain is yet undetermined, yet they have the chronic pain problems. A lot of times they present with different pain, acute on top of chronic pain, and I say please work them up, because a lot of times you do find organic pathology behind this. Take action and evaluate your results frequently and change them accordingly. Regarding pain scales, an observational pain scale, which is very popular, is the FLAC scale. It says infancy to 7 years of age, some reports to 4 years of age, children with developmental delay. It's the caregiver who provides this information based on the child's responses in terms of body language, the face, whether it's grimacing, the legs, the position of the legs, activity, ability to console that child. Is the child not very active or crying incessantly? And based on those scores, a determination of how severe the pain is made. Regarding self-reporting scales, at the age of 3 and above, different types of scales are used. The Wambaker-Facey is a hugely popular scale that's used in the clinics, as is the Oucher. The Oucher is more culturally sensitive, but children can identify, with the face as to the amount of pain that they're actually experiencing. Above 12 years of age, you can use numeric rating scale, and 4 to 12, you can use various color scales, and really it depends on the child's ability to quantitate and act consistently and reliably report. Different types of pains. Now, I know you've heard several things about nociceptive pain, neuropathic pain, and mixed pain, so I'm not going to go into it too much. Nociceptive being that inflammatory pain, neuropathic pain being that abnormal pain processing that the children will report, that stabbing, searing, burning type pain picture. And most of the time, the pain that's reported in my clinic is a mixed type of pain. One of the things when the kids do present, I tell them that there's no magic pill. I mentioned a mega workup before. The extensive workup a lot of times has led to several medication regimens that have been trialed and failed for various reasons. So by the time they get to me, I tell them that really it's not going to be medication dependent for significant relief of their pain, but it's going to be a comprehensive approach, which is going to sometimes involve medication, rehabilitation, education, nutrition, psychology, and integrative medicine. The World Health Organization initially came out with a 3-step approach to the management of acute pain. It was by the clock, customized for the child, the appropriate route of administration in terms of no IM medications to be administered, more pain. And then this recently changed to become a 2-step ladder of approach to management in 2012, in which codeine was eliminated and tramadol as well. And the real recommendations are to go straight to low-dose opioids. So why did this happen? Well, mild pain management remained the same. Acetaminophen is able to be administered under 3 months of age, very little side effect profile. After 3 months, it's not been studied as well. That's why it's after 3 months is ibuprofen recommendations. You do have a little bit more of the side effect profile in terms of hepatic and GI bleeding, etc. Both have to be adjusted if, in fact, there's a nutritional deficit that's occurring with the child. Ketorolac is very good and frequently forgotten in acute pain processing problems that are happening. Regarding the codeine, codeine is weak opioid. It's really not the active metabolite. It's morphine. In order to be metabolized, it has to undergo a cytochrome P450 system, and it is CYP2D6 that, in terms of the activity of that, it's very variable, especially when the newborns, and from 0 to 5, it's not a very active system. So Tylenol #3 has kind of falling out of vogue in terms of being prescribed, because it's felt that really not a significant amount of analgesia is reported with the usage of codeine. You have also the opposite side, the ultra rapid metabolizers, which a lot of times are culturally like the African Americans, and this could lead to toxicity. In breastfeeding moms, this could also lead to the child being overdosed as well. So you have to be very careful. So codeine is not recommended anymore. So recommendation regarding tramadol, not enough research to support its continued use has been noted. So recommendations to go to low-dose morphine right away for moderate and severe pain and titrate up to effect. You may ask, well, what about oxycodone and hydrocodone, which also use that cytochrome P450 system? This is true, but they've not been eliminated because there's been very little difference in the metabolizers between poor metabolizers and normal metabolizers. The overall analgesic effect appears to be the same. This is just the options of opioids. I have to be honest, I don't use opioids in my management of the pediatric chronic pain population. I use it as little as possible. Usually it's a patient I've taken care of on an inpatient basis and they transition to outpatient, and my goal is to get them off as soon as possible. Non-opioid pharmacological options I am definitely much bigger with. Membrane stabilizers such as gabapentin and Lyrica are frequently used. Gabapentin is extremely well tolerated in this patient population and usually very little side effects reported. Pregabalin, however, especially with female teenagers, there's a lot of weight gain, and a lot of times they're not very happy about that, and so they choose to stay on gabapentin. I've heard that Lyrica, though, is a lot more effective at managing the pain. Tricyclic antidepressants are huge. However, suicidal ideation is a contraindication to its usage, and surprisingly, quite a few of my patients have had this. So it's not being used as frequently as it could be used because of this. But they're very effective, a lot of bang for your buck in terms of they allow you to get sleep. A lot of times they do improve mood, and they do help with pain. Regarding the muscle relaxants, acutely, Valium, diazepam is used and seems to be effective in a certain population of patients. Muscle relaxants also with the baclofen. Being a physiatrist, I'm familiar with baclofen for spasticity, so I don't tend to go to baclofen as a first line of choice. I will use the Valium though early on, and it seems to be effective. Regarding therapeutic options, education is paramount. It's at the center of everything. So to keep the patient and parent well informed as to what you're doing and why you're doing, it really helps to assuage their anxiety and help them with compliance of being in the program as well. Regarding rehabilitation, being a physiatrist, this is what I really push. Functional restoration programs. So many times children are deconditioned. They come in and they feel that moving less helps them with their pain, when exactly the opposite is what's really true. So I try to get them active and going. A lot of them have no longer been involved in extracurricular activities, especially sports programs. Aquatic therapy is fantastic. With gravity eliminated, patients are frequently able to build strength and movement early on, and then physical therapy and occupational therapy come in after and really do a good program. Regarding behavioral health, it's paramount to anybody coming into the program. We have a pediatric psychologist that does the screening, and usually many of the patients require follow-up management regarding whatever it is that may be at the root of their problem. Pain is real, but frequently by the time they come to a chronic pain specialist, it's been long-term and affected many aspects of their day-to-day lifestyle, as well as the parents as well. So it's not infrequent that parents will come and also be a part of that session, maybe at the beginning or the end. And measures such as biofeedback and guided visual imagery are very effective. We've been very fortunate to have a grant here at UNM with the Center for Life Integrative Medicine Program, in which our patients are able to receive acupuncture and myofascial therapy. I can't tell you, art, music, and dance are also very effective. Meditation and nutrition. Nutrition can't be underplayed It's very important. There are various foods that lead to inflammation, and it helps a lot of times if they're eliminated from the diet as to how the patient functions from day to day. The impact on my population of patients is usually humongous. By the time they get to me, most are not even able to, a lot of times, attend school. School attendance is very poor. They're not active, as I mentioned earlier. About, I think, 70% of them have daily life restrictions in what they do, how they do it, and when they do it. The sports participation has fallen off dramatically. Peer relationships become strained. If you're always aching and ailing, nobody really wants to be around you. They don't invite you out as much. This leads to some mood problems a lot of times with these patients. And although this says 50% sleep difficulty, I would say in my population of patients, it's about 75 to 80% of sleep problems. Potential for permanent alteration in child's development and future role of function. Unfortunately, I have witnessed it in the patients that I've followed long term. A lot have had very high aspirations and were high achievers prior to having the pain problem, and now have had to scale down their aspirations tremendously. I really urge that they stay in school in an academic setting on a regular basis and graduate from school and go on to college and become a functional part of society. And this has happened although they've had to make changes. Poor school performance, especially initially, is not uncommon. Secondary to multifactorial reasons, the medications, the insomnia, the ability to just move and get to school. So frequently 504 programs are put into place, and letters are written all the time for these patients. This is the second half in terms of the opioid addiction piece that needs to be addressed. McCabe did a study in 2009 that was in the Archives of Pediatric Adolescent Medicine, in which he looked at the motives for non-use of prescription opioids amongst high school seniors. It was about 50,000 that he surveyed. And what he found that was very important was that non-medical use of opioids was highest in the 18 to 25-year-olds. 1 out of 10 seniors reported the misuse, but it wasn't necessarily to get high as it was to relieve the pain. What was very interesting in the study is that for patients who had chronic pain as a diagnosis, misuse was very rare and addiction was very rare in this population. They were really using it for alleviation and analgesic properties. A lot of times their expectations were inappropriate, but they were not abusing the usage of it. Motives for non-medical use of opioids were high in a certain population of patients. They used it to get high, and to 45% used it to relieve pain. Those who used it to get high also were smoking and drinking, so they had a lot of other factors involved with that. Regarding adolescence and young adulthood, the recommendations are, and what has been found in a lot of the studies, is the highest risk factor for drug experimentation and abuse are during periods of major transitions, whether it's a change of schools, change in the household, a divorce, the death of a family member. Social, emotional, and educational challenges also put patients at high risk. Increased availability of drugs in the cabinets, grandparents' houses. So the key thing to do, and this will be said frequently in this half of the lecture, is to lock up the prescription medications, because in patients that are in areas of poverty, where there's a lot of times increased drug availability and lack of parental supervision, this is a key factor in helping to decrease this. The FDA put out a comprehensive action plan to address the opioid abuse epidemic that was happening and the overdoses that were occurring. And they looked at different populations which are at risk. And regarding the pediatric population, increased transparency was the overarching thing for every population. So with pediatrics, they've gotten together a group of experts to convene and make recommendations about the medications, the opioid medications, which are being approved before they're approved, especially those that don't have the inherent property of decreasing abuse potential. They also will provide the opportunity for public input. And recently, there has been the approval of extended release hydromorphone for chronic opioid user populations, such as sicklers and cancer patients as well. Increased communication within the medical community is their goal. In terms of the American Society of Addiction Medicine, they had a facts and figures page that was issued in 2016, and they too were looking at the or addressing the concerns of the opioid abuse and overdoses that were taking place, and they looked at special populations. And in looking at the adolescent population, ages 12 to 17 years of age, there were about 500,000 current non-medical users of pain relievers, and they had about approximately 170,000 that admitted to being addicted. And the use of heroin over the past year was about 30,000 during 2014, and those that were addicted to heroin were about half of that, like 16,000. And what they found was that it was easy for this group to get medications that were not prescribed. They got it for free most of the time. And prescribing rates for prescription opioids during 1994 to 2007 had nearly doubled. The new statistics I know are going to be lower than that. Regarding New Mexico's substance abuse and epidemiology profile, this right here is just a chart showing the resiliency factors that have been very effective in preventing drug overdose and usage: caring and supportive relationships, positive peer influences, high expectations within the community, caring and supportive relationships in school, behavioral boundaries being followed at school, and involvement in school activities. When you look at New Mexico compared to the United States, youth substance abuse and illicit drug dependency were higher in all areas from 2009 to 2013. And the interesting thing is that there's not been much change from that time period. In terms of treatment programs, it's only about 13% of patients. This was pretty much in concordance with the national average as well, that actually seek treatment with this population of patients. This right here is a reminder of a case presentation that I had done, just to remind folks that what I do as a physiatrist is I handle brain injury, and I have seen quite a few of this age group of patients that have suffered a severe anoxic brain injury secondary to drug overdose, and they've been severely affected in their overall function, both in cognitive and physical abilities. It requires complex coordination of care and ongoing services that are very costly. New strategies for treating addiction amongst teens in New Mexico. Recently, we had the pleasure of visiting this program. Jennifer Weiss-Burke started this program out of her homage for her son, who had been addicted to heroin and lost his battle with it a few years back. And she created a program realizing that with teen addiction, it's not the same approach that's needed that's used with adult addiction. One size does not fit all. And so she's developed this residential treatment center that's absolutely beautiful. Initially, it's been directed towards the male population of patient, post-detox program that's usually about 6 months in which the patients reside there. A lot of education, they're encouraged to get their GED, and a lot of transition to community aspects are really emphasized, and they've had a lot of success with this program. I do know that they're planning to have a female section added to the program as well, and good things are expected, but it's nice to see that that's been here in New Mexico to address this very traumatic problem that we have here. In summary, hopefully in this brief discussion, you've been able to understand some of the barriers that we've had to overcome in treating pediatric chronic pain problems, some of the lack of recognition, some of the fear in actually treating these patients, and the undertreatment that happened for decades, and The ability to assess how these patients are doing on an ongoing basis being very helpful, and the correct uses of the pain scale, the appropriate pain scale for the patient according to age, cognitive function, and if not that, the caretaker's reliability and accessibility to report it. The use of the pain approach to management, the elimination of step 2, and just having now a 2-step approach instead of a 3-step approach, and why that's occurred. And the approach to management comprehensively, in not going to medications so much, but trying to emphasize therapies that will improve function. A lot of times we're not able to totally alleviate, eradicate, or abate the pain, but still yet having the patient become functional is huge. Consider risk factors involved in the misuse of painkillers, lock up the medications, and look at the population. Don't be afraid to speak to the parent and the patient regarding what they are taking and how it should be used, and not to share. Include resiliency factors in your education at every patient visit. Are we there yet? Not quite, but I think we've made very large strides in trying to achieve our goal. Thank you.
I think that this talk really is good timing because it's after Dr. Bott's morning talk on screening for opioid addiction, misuse, and diversion, and it's also falls after Dr. Camerata's talk on opiate medication for pain in terms of safe opiate prescribing. What I'd like to talk to you about is the use of naloxone really as a harm reduction measure and how effective it has been in terms of saving lives in the community. It has been one of the most effective tools for saving lives as a community outreach measure, both in rural and underserved communities in Indian country. And Dr. Bott, and Dr. Ford will probably mention is that the Bureau of Indian Affairs just had a huge training a couple of months ago, and now every BIA agent is now carrying naloxone on them. It has been effective in community outreach dispensing with prescription opiates. It has been extremely effective in syringe exchange programs, and law enforcement agencies all over the country are now carrying naloxone as they take calls from citizens who are thought to be kind of down and out and unresponsive. I do not have any disclosures. One conflict, I do have a small research grant with Kaleo that should be added to this. Kaleo is a pharmaceutical company that does produce one of the 2 FDA approved products for naloxone. So as you can see, over the past decade, we've had just a uptick in prescription opiate pain reliever deaths, both men and women. And this is prescription opiate pain reliever. And then on the next slide, you'll see the huge uptick in heroin overdose deaths, more so from men, but also with women, especially in the past 5 years. So who are the populations at risk for accidental overdose deaths with prescription opioids? Again, this is prescription opioids and not heroin. But it's really anybody with a prescription for an opioid medication really can be at risk for an overdose death. Remember, risk is fluid. It's not just someone who's on a huge, massive dose of an opioid analgesic that might also have sleep apnea, that might also be taking a benzodiazepine, but it can be the patient who's on a stable dose of hydrocodone, who then develops who might be elderly, who then develops a pneumonia with a fever, who's admitted to the hospital, and their doctor increases their dose of opioids, and all of a sudden they're at much higher risk for an accidental overdose. They might go home, their dose of opiates remains escalated, and their pneumonia, unfortunately, is not completely resolved, and they might have an accidental overdose. Again, patients taking opioids exactly as prescribed might have a risk because they might add alcohol to the, just like we mentioned the previous, during the question and answer period. The patient is taking alcohol or a benzodiazepine or other substances, even like Benadryl or other respiratory depressants. Patients taking opioids exactly as prescribed, and also other CNS depressants, like I mentioned. Patients altering the intended route of administration, sniffing their opioids, injecting their opioids. Those without a prescription for opioid medication, that 55% of that pie chart that I mentioned, opioid misuse, that's the biggest route. The most patients who are dying of opioid overdoses from prescriptions are not getting their medications directly from a doctor. They are getting their medications from a family member or friend. Those using opioid prescribed for another, and those who use illicit opioids. What are potential risk factors for opioid overdose? This came from Project Lazarus, which was out of Wilkes County, North Carolina, approximately 6 years ago, when Fred Brazen did a very large successful study looking at patients near Fort Bragg, North Carolina. There's a big Army base there. Were taking large doses of prescription opioids, and they had a much higher overdose rate in this part of the country near Appalachia than in many other parts of the country. Well, he started co-prescribing, or actually he started giving take-home naloxone, and their overdose rate dropped in half. These patients not only had large doses of opiates prescribed to them, they were smokers, they were using alcohol, tobacco, some were using marijuana. These patients also had renal disorders, depression, anxiety, and other medical conditions. Patients who were on high doses were deemed to be high risk, and patients who were also converting from one opiate to another, or an opioid rotation. What are some other potential risk factors? We know that the use of methadone, which has a very large half-life, very long half-life, is thought to be much more risky, and more patients die of methadone proportionately than other types of opioids, as well as long-acting opioid formulations as compared to short-acting formulations. We know that the concomitant use of central nervous system depressants, and I've mentioned this many times, and Dr. Commercy will also talk about the harmful product Carispidol or Soma, which is billed as a muscle relaxant, but really has no muscle relaxant properties, but really its breakdown property is of meprobamate, which is a barbiturate. So patients who are using not only opiates, but benzodiazepines and Soma, they call this in many parts of the country, they call that the Holy Trinity, because it is actually quite so deadly. And actually in combination with alcohol, it can be quite harmful. A combination of that plus hepatic and renal disease really is quite dangerous, along with pulmonary and sleep apnea. Again, I mentioned Project Lazarus because this study really started many other community outreach projects which showed the benefits of either co-prescribing naloxone, which means writing a script for naloxone and actually hoping that the patient goes to the pharmacy and gets the script, or actually giving the patient naloxone right then or there on site, either in the community or in your clinic, which would mean take-home naloxone. There's been many other community projects, such as in Massachusetts, in our own state here in New Mexico. We have a lot of outreach going on in syringe exchange programs in northern New Mexico. There's many law enforcement agencies now, big cities that are carrying naloxone. Many law enforcement agencies in New Hampshire and Massachusetts and Baltimore, most of our policing agencies in New Mexico are carrying naloxone. The Bureau of Indian Affairs is carrying naloxone, and it's shown to be very, very effective. Some things I might add is that co-prescribing of naloxone has shown to decrease emergency room visits. It's shown to, in other studies, they are giving it not to everybody, even though we know that risk is fluid and anybody can have an increased risk at any time, but they've chosen, because it's not cheap, naloxone, they've chosen to give it to high-risk patients, and they've shown that this is beneficial in patients in multiple ambulatory clinics in San Francisco. Something about the benefits of naloxone. It seems to have more impact in patients who are injection drug users than patients who are using high doses of prescription opiate medications. One possibility is that injection drug users tend to inject with their friends and do not use heroin by themselves. And so in syringe exchange programs and possibly in medication-assisted treatment centers, this might be a very, very good starting place to co-prescribe or to give take-home naloxone. This might be more fruitful than in ambulatory settings where patients are at high risk, but using prescription opioids, but tend to use these medications by themselves. In social settings like with injection drug users, the naloxone can be used and distributed to patients, and there have been shown to be many saves within this population because of the social network. So my feeling is that this really should be a universal precautions model, not unlike epinephrine for patients who have bee stings, or glucagon for patients who have diabetes, or if you're as old as I am, you might remember Ipecac for your infant or toddler. If your little one or a baby had swallowed a poison, you would give that medicine to have them vomit up the toxin that's now taken off the market because it was found to be deleterious. But the co-prescribing of naloxone for all patients using opiate analgesics for chronic pain, cancer pain, and medication-assisted treatment, it really assumes that risk is fluid, and it really gets the medicine into everybody's home, because you never know who's really going to have an overdose and when and where. Now let me just tell you a little bit about the routes of administration. The 2 FDA-approved products of naloxone are, one formulation is called Adapt, and it's a nasal spray, and one formulation is called Evzio, and it's an auto-injector. These are the 2 FDA formulations. There's also a generic formulation that I believe is on formulary in all IHS facilities. Is that right, Dr. Ford?
Yes, that's my understanding.
Okay. So there's 2 FDA formulations. They're both the exact same dose, which is 0.4 milligrams per milliliter, and the same with the generic dosing. And here are some resources for you. I would recommend prescribing naloxone for every patient who is on an opiate analgesic, because it provides a way for you to educate your patient. It takes minimal amount of time. Now just a couple minutes on disposal of medications and take-back programs.
Can I just jump in?
Please, Dr. Ford.
This is Dr. Ford. I did want to point out something Dr. Katzman mentioned earlier, is that earlier this year we signed an agreement with the BIA to provide naloxone to all BIA law enforcement officers. I believe, and certainly pharmacists out there can correct me on this, I believe all of that training has been done. So now there are, I believe, 800 or maybe 1,000 officers carrying naloxone that is provided to them from IHS. I have heard personally of saves by the officers. Someone here mentioned officers and first responders. I think, yes, that is certainly a place where they need to have that medication, especially when you look at some of our reservation communities where they may come on someone and it may be an hour ambulance ride to the clinic. having them carry multiple doses is a good thing. So you will definitely hear more about that. I would say that I don't know that that replaces having it with the patient and the patient's family. I think there's a need for both. Obviously, the cost is an issue, but I do think that both is sort of best practice. And again, we will have a training on co-prescribing in the next month or two. So I'm sure we'll go into more detail on that. But I did want to make sure people are aware that BIA law enforcement are carrying this. Also, many IHS facilities have entered into agreements with tribal law enforcement, so your tribal police may also have it as well. We just couldn't do that under one umbrella MOU. So just put that out there.
Thank you, Dr. Four. What I would also say, and I thought Dr. Four was going to mention it, but he left it for me. So thanks, Dr. Four, is that sometimes patients will require one dose to have a reversal or a save. Sometimes patients require 2 doses of naloxone, and now more and more often patients are requiring actually 3 doses of naloxone. A kit of Evzio or a prescription of Adapt, the 2 FDA formulations and the generic, will give you 2 doses. But once in a while, the patient will require 3 doses of the naloxone in order to come back to consciousness. So if you do get the training and learn how to educate your patient to use the naloxone, the bystander, the family member, the friend, the relative who is using that naloxone really needs to give the patient the dose of naloxone, then call 911 and stay there on the scene. 35 U.S. states have the Good Samaritan law, which really protects that bystander from any legal consequences, except for if there's a felony warrant for their arrest, or if the patient if the bystander has is under probation, or if there's drug paraphernalia around, there's low likelihood that they will be arrested. So the reason why sometimes there's going to need to be 3 doses is high doses of methadone, fentanyl, and then there's these very, very high potency new medications out here now from China, from Mexico, that are fentanyl-laced heroin and new fentanyl kind of products that are have been deadly in many, many cases throughout the country, and can need 3 doses. Okay. So just a little bit now on medicine take-back programs. Really, you need to go to your local waste management authorities to learn about where you can teach your patients to dispose of their opiate analgesics should they not need any more. Let's say you've had a surgery and your doctor gave you, 60 oxycodone tablets and you used 5 and you've got 55 left, and you don't want your family members, your young kids, or your other neighbors to come into the house and get a hold of this. There are ways that you can learn about where you dispose of this. You do not take this back to your clinic. Your clinic cannot be the recipient of these 55 oxycodone tablets, nor can your local pharmacy, unfortunately. Sometimes you can call your local law enforcement agency, and there are take-back days, and they will know. You can go online to find out about the next take-back days. There's some websites here for you. The U.S. Drug Enforcement Administration periodically hosts national prescription take-back days, but really the simplest ways are to dispose of it in your household trash. You can mix these medicines in an unpalatable substance such as dirt, kitty litter, or used coffee grounds. Okay? You place this mixture in a container such as a sealed bag, and then you throw the container in your household trash, so that it will not be obvious at all to anybody who might be kind of scouring through your trash. You scratch out all the personal information on the prescription label of your empty pill bottle and your empty medicine packaging. So really think about mixing the medicine in kitty litter, dirt, or used coffee grounds. Do not flush it down. Do not tell your patients to flush their pills down the toilet. And crush it up. Crush it up. Actually, yeah, okay. So Dr. Commercy, please chime in and help me here.
Sure, so I recommend, maybe putting it in a plastic bag and then taking a hammer to it so it's crushed and mixed with the kitty litter. Otherwise, you could take the pill right out of the coffee grounds.
Okay, okay. Sounds good. Sounds good. Thanks, Dr. Commercy. So one idea is to crush it up. Dr. Dole had, this was from Dr. Dole's talk, and he mentioned do not crush the tablets or capsules. So I think either way is probably okay. The main thing is to put it in something unpalatable.
I'm not so sure why.
Right. Right. So the main thing is to get it into something unpalatable, unrecognizable. And I would say to crush it up too. I would agree, Dr. Commercy. And here are basically more information on a collection of the goods. And basically, these are medicines that can be flushed, although what we have said over the last 6 or 8 times that we have come and done this talk each year is it's better actually just not to flush any medicines down the toilet for ecological purposes, okay? And I think I'll leave it at that, Dr. Four.
Can we maybe just address a couple of
Yes.
questions related to this topic?
Yes.
So someone's asking, if you're giving naloxone with your opioids, aren't you just sort of giving them permission to take too much opioids? I mean, could you actually increase the risk of an
Yes.
overdose because now this
Yes.
person has this safety net, if you will?
Yes.
Is that an issue?
Yes, that's a fantastic question, and it's actually been, I'm actually doing a lot of research on this right now, and it's been refuted many, many times. There's actually no evidence that by giving somebody naloxone, they're going to say, hey, I've got this, got the naloxone in my pocket, I'm going to use more heroin or use more prescription opioids. That has actually been disproven, I might say, and not shown to be based in evidence.
And for those of you who may not know, I mean, naloxone, it basically puts them in withdrawal immediately, right? So it's not a very pleasant experience, I would not imagine, to go from being overdosed to being on naloxone. It's not something that is very rewarding for the patient.
No, not very rewarding. It puts the patient immediately in withdrawal, and actually, studies have also shown that most patients who come to medication-assisted treatment or come to want to start a recovery process, many patients have actually been rescued or been saved by naloxone, 1 to 3 times. So it actually being, rescued by naloxone actually helps. There's more of a chance that they're going to want to actually get on medication-assisted treatment and not actually the opposite of wanting to use more. Yes.
Right. And someone asked, what about naloxone dosing for pediatrics, for teens potentially,
Yes.
or maybe an unfortunate infant who has maybe ingested an opioid accidentally?
Yes.
Same dosing? Are there different
Yes.
kits?
Yes.
How does that work?
I believe, except for 2 months and older, it's the same dose. It's the same dose.
Okay.
And actually, this is quite a small dose, and that's why you can go to up to 3 doses. The maximum doses, or actually kind of an intermediate dose, is about 2 milligrams. So yeah, this is a pediatric dose as well.
Right. Great.
And Dr. Commercy, Dr. Chowdhury, please feel free to chime in too.
Right. And, there's a discussion about Marianne's wondering about, it's baffling that we want to not have opioids out in the community and yet, the pharmacies can't take them back. And my understanding is that's all federal DEA regulations,
Right.
that it's not that the agency or tribes don't want to, but they're very strict DEA regulations around those kinds of medications and take-backs because of risk of diversion and not being able to account for them, that once it's out, and then, it's with the patient, and to take them back, it's just, that would require change in federal law or
Right.
regulation. Is that?
It's not a change, it's not a law, it's just that the burden, the burden of accounting for those would be so enormous.
Got it.
And because they have to account for every single
Pill.
pill of a controlled substance. Now, if they've got this additional burden of having to deal with accounting of other controlled substances, it would just be an owner's responsibility.
Right.
Same reason we don't take them in clinic. We refuse to take them in the clinic when patients
Right. I can tell you that within IHS, the work group that I keep mentioning is looking to maybe get a national contract for take back, where basically that contractor, we would collect them, but then the contractor would be accountable for all of it. That's proven very difficult to find someone that could do that across 50 states. It's been quite a challenge, and what we have found is that it also would be quite expensive. So we're still looking for solutions as an agency, but it is not an easy problem to solve, unfortunately, even though it is such a big risk to have those medications out there.
Right.
So.
My understanding also, Dr. Four, is there's these machines that actually disintegrate these medicines and destroy the medicines, and they're extremely expensive.
Yeah.
Extremely expensive, yes.
Well, thank you